Welcome to this explainer. Today, we're diving into the incredibly delicate plumbing of the central nervous system. We're going to uncover exactly how disrupted cerebrospinal fluid flow connects three severe neurological conditions. You know, the brain and spinal cord are absolute engineering marvels. But just like any complex system, if the structural integrity is breached or the internal pressures get out of whack, the cascading effects are massive. Today, we are focusing exclusively on three distinct yet deeply interconnected anomalies: Spina bifida, hydrocephalus, and arteriovenous malformation.
So here is our roadmap for today. We'll trace this domino effect across four logical steps: the CSF flow connection, spina bifida's dual threat, hydrocephalus and shunt care, and finally, AVM, the vascular time bomb. We're keeping our focus laser tight to show you exactly how these specific conditions interact with one another.
Okay, Section 1, the CSF flow connection. Let's start by establishing what a healthy neurological ecosystem actually looks like before things go wrong.
So, cerebrospinal fluid, or CSF, this acts as the brain's ultimate protector and transporter. It completely relies on a delicate, unobstructed flow through the brain's ventricles and down the spinal cord to keep intracranial pressure perfectly balanced. Think of it like a dynamic hydraulic system. It's constantly being produced, it flows through these really narrow channels, and then it's reabsorbed. When everything is in sync, the brain is perfectly cushioned and nourished. But if that flow is blocked or misdirected, well, we run into immediate life-threatening danger.
Which brings us to Section 2, spina bifida's dual threat. Let's see what happens when there's a structural breach in this vital system right from the very beginning of life.
Spina bifida is a congenital structural defect, and it happens incredibly early in embryonic development. We're talking about the 4th week of gestation, when the neural tube fails to completely close. Because this happens so early on, the vertebral column, and in severe cases the spinal cord itself, is left partially unsealed. This structural failure fundamentally alters that closed-loop system of the central nervous system we just talked about. And there's actually a spectrum to this condition. Spina bifida ranges from spina bifida occulta, which is often just a hidden, asymptomatic bony defect where the spinal cord stays put, all the way up to myelomeningocele. This is the most severe common form, where both the protective meninges and the actual spinal cord physically herniate outside the body into an exposed sac. You absolutely cannot treat these as interchangeable. They represent vastly different levels of urgency and potential nerve damage. Now here is the really crucial point. This exposed spinal defect, especially in those severe forms, is a dual threat. First, it's literally an open doorway for direct implantation infections. Pathogens can just travel right into the central nervous system, which drastically spikes the risk of meningitis. Second, the physical downward pull of this defect actually shifts the anatomy of the brainstem, and that severely disrupts the normal flow of CSF, causing a massive backup in the entire system. And that exact disruption in fluid dynamics leads us directly into Section 3, hydrocephalus and shunt care. Let's look at the plumbing fixes required here. Now, it's important to understand that hydrocephalus isn't really a standalone disease. It's the direct pathological consequence of CSF building up. When that fluid can't flow properly, often triggered by the exact neural tube defects we just looked at, it accumulates. The ventricles dilate abnormally, and the intracranial pressure begins to climb dangerously high. Professor Dyer points out a really fascinating yet dangerous paradox here. An infant's flexible skull will actually expand to accommodate that extra fluid. Because their fontanelles are open and the sutures are unfused, the skull basically acts like a pressure release valve. But beware, this does not mean the infant's brain is protected. It just means the expanding skull is masking the classic signs of dangerous brain pressure until very late in the game. We literally cannot wait for standard pressure signs to appear in a baby. Because of those expanding skulls, we have to urgently watch for subtler cues in infants: an abnormally rapid growing head circumference, a high-pitched, almost cat-like cry, or what we call sunset eyes, where the eyes deviate downward. These are massive red flags. On the flip side, older children already have fused skulls. Their heads can't expand, so they're going to complain of severe headaches, vomiting, or visual disturbances much more quickly as that pressure spikes.
So how do we fix this plumbing issue permanently?
We have to bypass the blockage.
Surgeons implant a ventriculoperitoneal, or VP shunt. Think of it as a specialized alternate pipeline. It takes that excess, high-pressure fluid from the brain's ventricles, routes it under the skin, and safely dumps it down into the peritoneal cavity in the abdomen, where the body can just naturally absorb it. But, as with any mechanical plumbing, it can fail. And we need to distinguish between two distinct emergencies: a VP shunt malfunction, where the tube is just blocked or kinked, versus a VP shunt infection. When the plumbing is backed up, you'll see immediate signs of increased intracranial pressure, headaches, vomiting, or a bulging fontanelle. A VP shunt infection, on the other hand, means bacteria has gotten into the hardware. This shows up as a severe systemic infection, fever, a red and warm shunt tract, and extreme irritability. Both are absolute emergencies, so there's no wait-and-see approach here. If a malfunction is suspected, remember this absolute golden rule of care: never manually pump the shunt valve. Unless a neurosurgeon specifically orders it, keeping your hands off is absolutely critical. Why? Because while a blocked shunt is dangerous, creating an overdrainage of fluid by forcefully pumping it is just as deadly. Emptying those ventricles too fast can actually cause tearing and massive hemorrhaging. Moving on to Section 4, AVM, the vascular time bomb. Let's explore how a vascular anomaly can also completely derail the system.
So, an AVM, or arteriovenous malformation, is a congenital tangle of abnormal blood vessels. Normally, high-pressure arterial blood filters through a massive network of tiny capillaries, right? This slows the blood down before it enters the much thinner-walled veins. But in an AVM, that capillary bed is completely bypassed. High-pressure arterial blood slams directly into weaker veins. And over time, this intense pressure causes those fragile vein walls to dangerously balloon and weaken.
Honestly, the most terrifying aspect of an AVM is just how silent it is. To put it in perspective, 80 to 85% of affected children don't even know they have this structural defect until an intracranial bleed actually happens. Bleeding isn't some late-stage complication. For the vast majority of patients, it's their very first symptom. It is the single most common cause of spontaneous intracranial bleeding in kids.
Because it presents so suddenly, out of nowhere, recognizing a rupture is everything. If a child suddenly complains of the worst ever headache or shows a brand new neurological deficit like sudden weakness, that is an absolute emergency. It means the time bomb has ruptured. And, bringing this all full circle, if this AVM bleeds into the brain's ventricles, that clotted blood can block the flow of CSF. And what does that do? It triggers a secondary case of the hydrocephalus we were just talking about.
To diffuse this threat before it bleeds, medical teams rely on highly targeted interventions based on the AVM's size and location. This might mean conventional surgery to physically remove a surface tangle, or an endovascular embolism, where an artificial clot is threaded into the vessels to plug the leak. They can even use radiosurgery, focusing a radiation beam to slowly collapse the malformed walls over time. The entire goal is to eliminate that high-pressure bypass before it bursts. As we wrap up this explainer, I want to leave you with a thought. We've seen how a structural neural tube leak in Spina Bifida causes pressure to back up into hydrocephalus, and how a vascular tangle in an AVM can suddenly burst and derail the whole system. Given how deeply interconnected the brain's fluid and vascular systems are, and knowing that an infant's expanding skull actively hides the danger signs, what new clinical observations can we develop? How can we better catch these silent, building pressures before they cause irreversible damage in those who can't even speak up yet? Thanks so much for joining me on this deep dive into the brain's incredible yet highly vulnerable plumbing.